Welcome to this podcast from the Medical Journal of Australia. My name is Sam Hunt, the MJA's News and Online Editor. Today we are discussing new developments in treating kidney disease, including advice for general practitioners, how patients can get support, and how one specialist balances their busy life. My special guest is Professor Gopi Rangan, a nephrologist staff specialist at Westmead Hospital in Sydney, and a clinician scientist at the Westmead Institute for Medical Research. Professor Rangan, thank you so much for joining me today.
Sam, a real delight to be here, and thanks for the opportunity to speak to you today about kidney disease.
Gopi, before we discuss kidney disease, can you please give our audience a little bit of an idea about your professional background?
To call me by my first name. I'm a nephrologist staff specialist at Westmead Hospital. I've been here for 20 years, and I'm also a clinician scientist at the Westmead Institute for Medical Research. And I look after or provide clinical services for people with kidney disease in Western Sydney, and also have a specific interest in translational research in kidney disease and involved in clinical practice guidelines and clinical trials, as well as preclinical research. Our hospital's one of the busiest in the country, and our unit extends all the way from Auburn to Lithgow, and we've got over 900 patients receiving chronic dialysis, so we're a very busy renal unit and involved heavily in transplantation as well.
And Gopi, what is the prevalence of kidney diseases in Australia, and what kind of population subgroups are most affected?
Chronic kidney disease is a growing health problem in Australia. It's very common and potentially treatable, particularly by identifying kidney disease early. We can prevent the long-term complications of kidney failure. And about 6 million Australian adults are at risk of chronic kidney disease, and that's about 3 in every 4 Australians. 2 million people live with chronic kidney disease, and in Australia we've got over 30,000 people who've got kidney failure receiving either chronic dialysis or having a kidney transplant. And one of the biggest problems is that the disease is not recognised because it's often silent. Kidney function has to decline by more than 90% before people get symptoms. And that's one of the biggest problems because people don't often get checked and are not treated early. And some of the patient populations that are at risk of kidney disease include those that have cardiovascular disease, diabetes, who have metabolic syndrome, First Australians, and also other certain racial groups as well are increased risk of chronic kidney disease. So screening all those people or identifying those people early is very important.
And Gopi, would you say that these population subgroups are historically less likely to have access to health advice or a lower degree of health literacy and may not necessarily be able to seek support when they need it?
Absolutely. I think certainly in Western Sydney, where the population can be socially disadvantaged, they're often under-recognised, and there's an increased risk of chronic kidney disease in those populations. So particularly in Western Sydney, where we've got a significant cultural diversity. So about 60% of our population is born outside of Australia and have countries of birth from India, China, Lebanon, and South Korea. And they can often be socially and economically disadvantaged, which places them at increased risk of chronic disease, particularly chronic kidney disease, mainly because they may have less access to healthcare or less likely to go and see doctors to be screened. Simple things like blood pressure measurement, management of their cardiovascular risk factors, obesity, tend to be under-recognised, and they often do present late. The environment of Western Sydney and the way we live has an impact on that. There's less reliance on physical activity, greater use of the motor vehicle, less areas for recreation. All of those factors can have a big impact. Access to healthy eating as well is an important thing. So yeah, all of those factors compound together.
And let's look at kidney disease now from the perspective of general practice. As a nephrologist, what are some of the challenges that GPs may face in identifying kidney disease?
I think the main thing is the fact that kidney disease, as we mentioned earlier, is silent. and under-recognised, underappreciated. So it really requires a clinical examination, blood pressure measurement, history taking, and really thinking about the presence of those risk factors we discussed further: cardiovascular disease, diabetes, obesity, the populations that are at risk, and to really proactively think about screening those patients. A history is critical, so certainly family history of kidney failure, which might raise a genetic cause for the kidney failure, measurement of blood pressure in the clinic, not just as a single measurement, but ongoing repeated measurements, a urinalysis to look for proteinuria or hematuria, and a blood test measurement to look for elevated serum creatinine or reduced estimated glomerular filtration rate. So I think that's one of the biggest challenges, is recognising and proactively screening. And also I think it's a partnership, because people have to come in to see their general practitioner as well. And that's often some of the problems, is that people aren't self-aware of the issues and the problems. And so they don't get screened. They don't come to see their GP until late, when they start to get symptoms. And when you get symptoms of kidney disease, it can often be sort of at a very later stage of chronic kidney disease, where it's less possible to reverse kidney disease or slow it down. So I think the lack of symptom awareness is probably the key factor.
And Gopi, you and your colleagues recently wrote in Insight Plus for World Kidney Day. One of the topics you discussed was the condition polycystic kidney disease, PKD. Let's zoom in on that particular condition. Can you unpack that condition for us? How rare is PKD, and what's your involvement with the PKD Foundation here in Australia?
PKD is a family of conditions. They're inherited conditions, so they're caused by genetic changes in the DNA, genetic mutations, or we call them pathogenic variants. And there's actually a group of diseases. The most common type of polycystic kidney disease is autosomal dominant polycystic kidney disease. And this is, as you can tell by the name, inherited in an autosomal dominant manner. It affects 1 in 1,000 of the population, so a very common and prevalent condition. It's estimated that about 12 million people are affected worldwide, and about 20,000 Australians. It's the most common genetic kidney disease worldwide in adults. A second condition, which is less common, is a condition called autosomal recessive polycystic kidney disease. This is primarily a pediatric condition. It affects 1 in 20,000 live births, and it's often recognised in childhood. But in adults, autosomal dominant polycystic kidney disease is the main condition. It's the fourth most common cause of kidney failure. It affects about 10% of patients on dialysis. It's characterised by the formation of multiple cysts in the kidney, and there's typically a family history. So often mum or dad are affected, and a daughter or a son will be affected in an autosomal dominant manner. So it's often a multi-generational disease, and it's also complicated by other manifestations, cysts in the liver, spleen. It can also cause intracranial aneurysms, hypertension. The kidneys get very large in some people, causing chronic pain. And roughly about anyone that's affected with the condition, about 60% develop kidney failure by the age of 60. And I think polycystic kidney disease and genetic kidney disease are really the classical example of early identification and intervention. It's the same paradigm that we're really advising at this stage, which is early detection of kidney disease, early identification. You can make a significant change to the trajectory and natural history of the disease by identifying the condition. In terms of referral nephrologists, there's certainly people who've got impaired kidney function, declining kidney function are important to be referred. If I could just add also that the reason for emphasising this is that there are now new treatments that we can apply, not only education about the lifestyle interventions and blood pressure control, and that's what we've had for many decades, but really over the last 5 years, there's been an explosion of new drug therapies that can be applied and are quite effective in slowing down disease progression. So declining kidney function, heavy proteinuria, and any other factors that's suggest any systemic causes, not just genetic causes of kidney failure, but autoimmune conditions such as lupus, certain vasculitides that are sometimes less common. It's paramount to do not only blood pressure, creatinine and eGFR measurement and urinalysis, but a kidney ultrasound to look at kidney size and exclude urinary tract obstruction is essential. And a lot of these principles are covered in the Kidney Health Australia CKD guidelines, which has just been updated and released. And there's also a CKD Go app that general practitioners can download. And there's a range of other societies that GPs can also access. For example, as we discussed, PKD Australia, there's a number of other genetic conditions that cause kidney failure, such as Alport syndrome. Each of those have foundations that general practitioners can access. The Tuberous Sclerosis Society, which is another rare condition, Fabry's disease.
And Gopi, you've touched on new treatments there, and you've also discussed those new guidelines that GPs can access. Let's talk about the new treatments. It sounds like there are newly emerging treatments for kidney disease, and treatment has come quite a long way.
They have, and I think particularly over the last 2 years, there's been 2 new medications that were improved by the TGA for treatment of chronic kidney disease. Listeners would all be fairly comfortable with the things that have been applied in the past, including treatment of hypertension and goals of hypertension with ACE inhibitors and angiotensin receptor blockers. But the real breakthroughs in the last couple of years has been the sodium glucose transporters, the SGLT2 inhibitors, which have been almost applied universally in slowing down chronic kidney disease progression, also slowing down cardiovascular mortality as well in parallel. And that's something that we haven't mentioned, but people with chronic kidney disease have got a 20-fold increased risk of premature cardiovascular disease. And often historically, some of our patients with chronic kidney disease have unfortunately passed away with a cardiac event prior to even coming to dialysis. And I think the availability of the SGLT2 inhibitors will make an enormous impact over the next decade. There's really a great deal of hope that the prevalence of people reaching kidney failure will decline in the coming years with early referral and early intervention. Another class of drugs that's also become available is the non-steroidal mineralocorticoid receptor antagonist, Finarone. And again, both of these drugs are now available on the PBS with specific indications and hold great promise in what we'll see in the next decade. The number of new treatments that are becoming available is really very exciting in nephrology. So going back to polycystic kidney disease, just over 2 years ago, the first disease-modifying drug became available on the PBS called tolvaptan, and that's also indicated in people who've got stages 2 to 3 chronic kidney disease due to polycystic kidney disease, and it slows down disease progression. So Fabry's disease has enzyme replacement therapy. Tuberous sclerosis has the use of a class of drugs called mTOR inhibitors. So I think there's even more reason now to refer patients to nephrologists or to renal service so that some of those new treatments can be applied.
And Gopi, for GPs and patients alike, what are some of the key things that they need to consider when it comes to kidney disease?
I think, Sam, one of the really important things is not to forget the basic bread and butter aspects of care, and that includes what we call, I guess, lifestyle intervention. Maintaining the appropriate body mass index through diet and exercise is actually the cornerstone of treatment, as we know. And certainly applying those in the best way we can to our patients is really the bedrock of our treatments. And again, can slow down disease progression. I'm an eternal optimist, and I think, to be honest with you, I think if they can be applied early, we can definitely delay the onset of kidney failure in a lifetime. So yeah, I think those things are really important to remember. And of course, the other principles of avoiding medications that are nephrotoxic, avoiding volume depletion, investigating the cause of chronic kidney disease, and remembering to do the ultrasound as well, identifying urinary tract obstruction as a reversible cause and can make a huge impact to disease trajectory.
Let's shift gears now, and on a lighter note, as well as an academic nephrologist and a staff specialist at Westmead, you're also a reservist in the Royal Australian Air Force. Can you tell me, how did that come about and how do you juggle all of these different roles?
That's a good question. To be honest with you, I had two passions when I was growing up. One was flying and one was, I guess I enjoyed medicine, biology and mathematics. And so I always wanted to join the Air Force probably when I was 17. I guess I passed my HSC exam and ended up at university. So that pathway just took over. But later in life, I had the opportunity to enlist and become a reservist in the Air Force. And it's a fantastic opportunity. I think the best thing is about, I guess, providing service to our country and providing that support. And it's a great privilege. It's fantastic to be involved. And in terms of, I guess, the juggling, I'm just fortunate to have a good family, very supportive wife and family to be able to fit it all in.
And can I just ask, in the reserves, you are in the reserves in a medical capacity, is that right?
Yes, so it's primarily to provide medical support. I've provided support at a specialist level, but also as a senior clinician or a physician. So I've undertaken work as an aviation medical officer. I've been trained in aeromedical evacuation. I've also done garrison work. I've been involved in exercises and deployments. So it's been a great privilege to be able to support that, both from a, I guess, personal perspective, but also humanitarian grounds as well.
And finally, Gopi, before we sign off, for patients listening to this podcast who might be looking for more support for kidney disease, where can patients or families go?
There are a range of patient support societies for all of these less common conditions, such as PKD Australia. PKD Australia have been pivotal in raising awareness of the disease in Australia, have been involved in generating research grants, which have led a number of clinical trials in Australia. There's a clinical trial using metformin and versus placebo, which modulates a particular pathway in polycystic kidney disease, which is currently underway. They've provided research support in new techniques of genetic testing. One of the things that's become available on the Medicare benefit scheme is that we can now do genetic testing to identify specific causes of where we suspect a genetic cause for chronic kidney disease. And that's made a huge benefit, particularly in the area of family planning. And it's enabled couples to pursue pre-implantation genetic diagnosis. And that's been hugely beneficial. It's also provided answers to people who've been left wondering, I guess, what the cause of their disease is. Roughly 10% of kidney failure is due to genetic causes. And identifying these specific gene causes will really lead to further treatments down the track that are more directly based than even the drugs that we have now.
Professor Gopi Rangan, thank you so much for joining me today.
Thanks very much, Sam. Real pleasure to be here.
My special guest has been Professor Gopi Rangan, a nephrologist staff specialist at Westmead Hospital and a clinician scientist at the Westmead Institute for Medical Research. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thank you so much for listening.